We have studied the hip joint just recently, alright. So there are similarities and dissimilarities between the hip joint and the shoulder joint. Both are ball and socket variety of multi-axial joint, alright. Now the shoulder joint, the ball is the head of the humerus and the socket is the glenoidal cavity of the scapula. Remember the direction of the head of the humerus and the interface of scapula. What is the direction of the head of the humerus? Tell me. Upward, backward and medial. And the scapula is glenoid cavity is upward, forward and lateral. Alright. Now, if we describe the globular head, only this is 2/3 of a sphere and only 1/3 of this head, 1/3 of the head touches the glenoidal cavity. Only 1/3 of the globular head touches the glenoidal cavity. Head is as usual lined by the hyaline cartilage, which is thick at the center and thin at the periphery. In case of the glenoidal labrum, the glenoidal surface, there is thin, this is thin at the center and thick at the periphery. And as you know, the glenoidal labrum is a triangular shaped fibrocartilage that deepens the glenoidal cavity. This is a glenoidal labrum is a fibrocartilage that covers the boundary of the glenoid fossa, which is triangular on cross section. Now, about the ligaments of this joint. Number one is coracohumeral ligament, glenohumeral ligament, capsular ligament with the synovial sheath, and the transverse humeral ligament. And the transverse humeral ligament. Alright. Coracohumeral arch is not included in this ligament portion. Right? Now the coracohumeral ligament. Now, first to describe the capsule. The capsule of the, unlike any other joint, the capsule of the shoulder joint is loose and lax. Capsule of the shoulder joint is loose and lax to allow free movement of the head. On the scapular side, this is attached to the just beyond the rim of the glenoidal labrum. Alright. And on the medial aspect, it is attached to the close to the surgical neck. And in the inferior medial aspect, the capsule is lax and comes beyond the anatomical neck of the humerus, 1 centimeter, 1.25 centimeters below the scapula is of grandfather. And the humerus is a 5-year child, 5 to 6-year child. Okay. Come gentlemen. Come here. Hold it in anatomical position. Hold this bone in anatomical position. No, not the articulation, only anatomical position. All right.
Left side.
It is left sided. What made you call it a left sided humerus?
This one, medial epicondyle, facing medially and molecular process.
This is medial epicondyle. তো এখানে থাকলে এটা মিডিয়া রাইট সাইডে হলে মিডিয়াল এপিকন্ডাইল হয় না? Take it on the right side.
But the head is on the lateral side.
Rotate it.
Olecranon process will be facing backward.
Olecranon fossa will be backward. What's the problem? Articulate it. Is it alright? Scapula is described that it is a flat, irregular bone. Alright? It is a flat, irregular bone. It has 3 borders, 3 angles, 2 surfaces, and 2 processes. Number 1, 3 processes. The spinous process, acromion process, and coracoid process. Alright? This one is its upper border. This is the vertebral border, and this is the lateral border. Alright? This one is the superior angle, this one is the lateral angle, that is the glenoid, and it is the inferior angle. This is the ventral surface, and this is the dorsal surface. On the dorsal surface, you see a projection, bony projection. Alright? Whose anterior part is attached to the dorsal surface of the scapula, and posterior part is projected out, and its upper border gives a crest. This is a crest-like formation with 2 borders. One is upper border and is the lower border. This is the basic or minimum description of the scapula. Why we say this? Because we need to know where is the supraspinatus. This fossa is the supraspinatus fossa. This fossa is the infraspinatus fossa, and this is the subscapularis fossa. Alright, as I have told you, the serratus anterior from the upper ribs, it comes like this below the subscapularis. From the thoracic wall, it comes below the subscapularis and gains attachment into the ventral surface of this vertebral border, right? And in its lateral border, this ventral surface is included in the origin of the subscapularis. Alright, above there is infraglenoid tubercle for the long head of biceps, and the supraglenoid tubercle for long head of triceps. Alright, this is the coracoid process, and this is the acromion process. Here you see there are origin and insertion of 2 muscles. Alright, this is the deltoid from the lower lip, and upper lip is the trapezius. Alright, and at the lateral border we see posteriorly there are 2 heads of teres minor and there is the teres major, and below there is attachment of latissimus dorsi. Alright, very good. Now remember this infraspinatus muscle, and this is the suprascapular notch. Alright, and it is glenohumeral. This is glenohumeral notch. Alright, this, if you pass a thread through this to this and encircle this, this will be actually the neck of the, this is actually the neck of the scapula. Alright, have you seen cutting of lamb or goat? দেখেছো? ঠিক আছে, ওরা কি করে স্ক্যাপুলাটা এইখানটাতে একটা, they chop here and around here, then they break it. ঠিক আছে, এটাকে ভেঙে ফেলে এরকম করে, ঠিক আছে, that is the glenohumeral notch and the suprascapular notch for the passage of suprascapular nerve and artery. This comes from here, passes through this to the up to the infraspinatus. All right. One thing again important is the infraspinatus muscle is divided by several septa, and the tension in between the muscle fossa and the muscle is quite high. The tension in between the septum, its fossa, is quite high. So in case of fracture of body of the scapula, there is large hematoma within this, and this is too painful. এইখানটায় ব্লাড জমে যাবে, ঠিক আছে, পড়লে এইখানটাতে ব্লাড জমে যাবে, there is accumulation of blood because of high tension within the infraspinatus muscle, right? Subscapularis tendon comes like this at the front of the, you see at the margin of the glenohumeral fossa, you will see in the anterior border there is a notch for the passage of the subscapularis tendon. এইখানটা দিয়ে subscapularis tendonটা এরকম করে পাস করে, ওইখানে দেখবে একটা anterior border of glenoid fossa তে there is a notch. All right. So this is the passage of subscapulary. Now, if you are asked to hold this in anatomical position, about what you should be sure? That the head is held upward, backward and medial, right? So this will be like this, upward, backward and medial. This is how a long bone is described. একটা লং বোন কি করে ডেসক্রাইব করতে হয়? This is upper end, this is the lower end and this is the shaft. Now you describe what are the features of upper end, what are the features of lower end and what are the features of the shaft. All right. And at the end you will mention how to hold it in anatomical position with side determination. All right. As I have told, the direction of the head, then you will see at the lower end back there is olecranon fossa. All right. The medial epicondyle is much projected than the lateral epicondyle, right? And in front there are two fossae, there is a radial and coronoid fossa, right? Laterally there is the capitulum, this one is the trochlea, and behind this bone deltoid irregularities has been removed almost. Laterally, just near the middle of the bone, middle of the sac, you will see a rough elevation for the insertion of the deltoid. All right. এই জায়গাটা deltoid insertion. Just opposite to that, there is another rough elevation for the insertion of coracobrachialis, and there will be a spiral groove behind. And this is the greater tuberosity. This is the lesser tuberosity, and in between is the bicipital groove or intertubercular sulcus through which the long head of biceps with a synovial sheath passes. With a synovial sheath passes. Behind this, on the back of greater tuberosity, there are three impressions for muscle attachment. Number upper one is the supraspinatus, middle one is the infraspinatus, and lower one is the teres minor. And the lesser tuberosity gives attachment to the subscapularis. Lesser tuberosity gives the attachment of subscapularis. ठीक है? Come here. Describe this bone, telling that it is a long bone. All right. It has upper end, lower end, and shaft. Then describe it. घुरे जाओ, उधर दिखे घुरे जाओ. Okay. हाँ. Tell the features.
This is upper end. This is lower end. This is intervening shaft.
The upper end has the head, greater tuberosity, greater tubercle, and lesser tubercle. All right.
And
Head is directed.
medially.
All right. Medially,
Anterior, and
medially forward and medially forward. No. Medially upward and backward. No. Give me the description of lower end. Okay. Lower end has two foci in front. I will be able to identify it is lower end. This is the radial and choroid fossa. And there is a deeper one or a larger one is the olecranon fossa. All right. There is greater projected medial epicondyle, and this is the lesser projected lateral epicondyle. All right. The rounded portion on the lateral aspect is the capitulum, and pulley-like articular surface is the trochlea. So the articular surface and non-articular surface. So describe the lower end in this manner. All right. Okay. Go back to your seat. Now let us describe the capsular ligament of the capsule of the hip joint. Laterally it is attached around the neck of the humeral head, neck of the humerus. All right. And medially it is around the margin of this glenoid fossa. All right. And at the margin there is the glenoidal labrum. That is a fibrocartilaginous rim on cross section which is triangular. Now at two places this capsule is deficient. At two places this capsule is deficient. Near the supraglenoid tubercle, where from the long end of the biceps is coming down. And another is at the inferior medial part of this neck. At the inferior medial part of this neck, which is protected by the long head of triceps. Which is protected by the long head of triceps and teres major. Remember one thing, that this is teres minor. Teres minor comes from here to back, from here to here, lower impression of the greater tuberosity on the back. So it is back to back. But the teres major from here, from the lateral border, posterior surface of the lateral border, teres major from here, it passes upward and medially. So it is from the back plane to the frontal plane. You got the point? Teres minor is like this, back to back. This is the lateral border, posterior aspect of the lateral border, and this is the lower impression of the greater tuberosity. So teres minor is like back to back, but teres major, that is from here. Teres major will come not back to back, it will come towards the anterior aspect of the humerus. Anterior aspect of the humerus to be inserted in the medial lip of the lateral lip is the pectoralis major, medial lip. So it will come like this from the posterior to anterior. That is the teres major. Will be inserted in the medial lip of the intertubercular sulcus, and in the floor there is latissimus dorsi. Right? This much location of muscle you should be able to memorize. Now I was telling about capsule. Now this is the capsule is strengthened by 4 short muscles. Number 1, supraspinatus, infraspinatus, long it up. No. Supraspinatus, infraspinatus, teres minor, and what? And what? 4 muscles? One is missing from my memory. Oh, subscapularis. Supraspinatus, infraspinatus, subscapularis, and teres minor. Their fibrous sheath expansion that covers which attaches to the capsule, strengthening it. This is called guardian of the shoulder joint. This is called guardian of the shoulder. So the rotator cuff, by the ensheathment from the 4 short muscles that strengthen the capsule, is called the guardian or the rotator cuff. Rotator cuff, that is the guardian of the shoulder joint. Alright. So the capsule distally attached to the, just beyond the rim of the glenoidal labrum, and medially it is wrapped around the neck of the humerus, and inferiormedially it is lax, more lax, and comes to the 1 centimeter or 1.25 centimeter more medially, and this part is supported by, here there is axillary nerve and posterior circumflex femoral artery, alright, and this part is supported by the long head of triceps. This part is supported by long head of triceps, right? Now the coracohumeral ligament. Coracohumeral ligament comes from the lateral border of coracoid process. Lateral border of coracoid process, and is attached at the neck in between in the region of 2 tuberosities. So the coracohumeral ligament is like this. From this lateral border to here. Coracohumeral ligament prevents lateral rotation. It prevents lateral rotation. Parallel to this coracohumeral ligament, we see 3 thickening or bands in the capsule of the shoulder joint. This is superior band, middle band, and inferior band. Parallel to this coracohumeral ligament, the superior band comes up to the upper border of the upper margin of the lesser tuberosity. The inferior glenohumeral band comes to the lower margin of the lesser tuberosity. Alright, I will draw a picture, don't worry. And the inferior band comes at the neck of at the inferior-medial aspect of the neck. So there are 3 bands, but you cannot be able to appreciate without incising, cutting the capsule of the shoulder joint. You will be able to see from inside, not from outside. From outside you cannot identify this band, and in between the superior and medial band there is subscapular bursa. There is a communication with the joint cavity, and sometimes from the back that is infraspinatus bursa. Right? Let me draw a picture. Understood? On the posterior surface of the lateral border, there are two impressions for the teres minor. From this, the muscle will come from back surface to back surface, on the back surface of the greater tuberosity. Alright? And below that, there is a large impression for the teres major. This will come from back to front. This will come from back to front on the lateral lip of the intertubercular sulcus. Understood? And the transverse humeral ligament. So coracohumeral ligament is this one from lateral border of coracoid process near the upper part of the neck. And there are three bands. Parallel to this, there are three bands. That is thickening of the capsule. That is the superior band, middle band and the inferior band. In between this superior and middle band, there is the bursa. There is the bursa. And the inferior medial part of the capsule is made loose and extends 1 to 1.25 centimeter around the inferior medial part of the neck of the surgical neck of the humerus, and which is supported by the, which is crossed by axillary nerve and the posterior circumflex humeral artery, and this part is protected by the long head of triceps and the teres major. Okay, and in between these two superior intertubercular sulcus, there is another ligament that is called transverse humeral ligament. This is called transverse humeral ligament. So this is the greater tuberosity and this one is the lesser tuberosity. This one is the lesser tuberosity. Lesser tuberosity carries the impression of insertion of subscapularis. Right? Here from the supraglenoid tubercle, the deltoid comes. From the infraglenoid tubercle, the long head of triceps comes. The tendon of the deltoid covers the anterior part of the head and goes down with the sheath along the bicipital groove. And the transverse humeral ligament that connects the two lips of the bicipital groove acts as a retinaculum to hold the tendon of the biceps attached with the bone. A greater tuberosity and lesser tuberosity, there is a transverse acetabular ligament that acts as a retinaculum. What does the retinaculum do? Prevents bowstringing. কতগুলো tendon, there are so many tendons, when they will try to contract, this will bend like this. This is called bowstringing, and the retinacular fibers keep the tendons attached to the bone so that there is no bowstringing. So the biceps tendon is prevented from bowstringing by this transverse humeral ligament. এই যে লিগামেন্টটা এখানে আছে, that prevents the bowstringing of the tendon of the long head of biceps. Got it? Now about coracohumeral ligament, glenohumeral ligament. Now comes the coracohumeral arch. This is not a ligament attached to the shoulder joint. Alright, this is a triangular arch, triangular ligament in between the tip of the acromial process to the lateral border of the coracoid process that prevents upward displacement of the humerus. When you abduct, the head has a tendency to displace upwards. Alright, this is prevented by the coracoacromial arch. Right? So capsule, to synovial sheath, nothing to mention about, as it is lax in the inferior medial part and the rest is alright. So this prevents the coracohumeral ligament also prevents lateral rotation and adduction. Coracohumeral ligament prevents lateral rotation and adduction. right? Now, nerve supply and artery supply. This you know. The posterior branches from the posterior circumflex humeral artery, suprascapular artery, and the subscapular artery, branches from the subscapular artery. These three arteries supplies the shoulder joint. And the nerve supply also you know, that is the axillary nerve, that is the anterior and lower part of this joint. Suprascapular nerve, the upper and posterior part of the joint, right? And the lateral pectoral nerve is the anterior and medial part of the joint. That is the lateral pectoral nerve. So there are three nerves supplying this joint. Alright. I will draw a picture for relation to show you the relations. Alright. So nerve supply and arterial supply. Let's see. This is supraspinatus, this is infraspinatus, this is teres minor. This is long head of triceps, this is teres major. In between these two, the axillary nerve and the artery comes down. This is subscapularis and this is pectoralis major. This is the deltoid muscle. Alright. Just have a look. I will draw in the next day. Right.